So if you look at this, imagine this is a bone, all right, and here we are having a tumor originated within the confines of the bone. Now this tumor is a malignant tumor and the tendency of the tumor is to spread. So the natural host defense mechanism of the bone will be activated in order to limit the progression of this tumor. How this progression will be limited? By the periosteal reaction. That means the periosteum will be activated, the cambium layer of the periosteum will be activated, and there will be a formation of a bony layer around the tumor in order to limit the progression of this tumor. But if the tumor is malignant, if the tumor is fulminant, then what will happen? It can easily breach this periosteal layer. Once it breaches the periosteal layer, there will be another foundation or there will be another attempt by the periosteum to contain the tumor. Similarly, it will be breached again, so there will be another attempt taken. There will be multiple other attempts which will be taken by the periosteum in order to limit the progression of the tumor. So every time all these malignant tumor related appearances are concerned, it is due to the periosteal elevation or periosteal reaction. Now, in case of osteosarcoma in particular, we have talked about the Codman as well as sunburst or rising sun appearances. Now, what it will lead to, or what are the principal reasons for that rising sun appearances? Imagine this is the primary origin site for the tumor, this one. All right. Now the tumor is spreading in the periphery. When it is spreading in the periphery, it is using this periosteal neovascularization. It is using the periosteal vascularity to spread towards the periphery. Now, when it spreads towards the periphery, all the vascularity will be assisting the peripheral movement of the peripheral movement of the tumor. All the vascularity will be inclined towards the peripheral movement of the tumor. The central core of the tumor, this one, will become more and more avascular. When the tumor is going towards the periphery, the central core will become more and more avascular. And when it becomes avascular, it will become necrotic. When it becomes necrotic, it will follow all the stages of the necrosis, and one of the important stage which is responsible for its appearance on the X-ray is the fourth stage of necrosis, that is calcification. When there will be appearing more calcification in this central core which is avascular and less calcification towards the growing side of the tumor, it will appear like a sun and its rays. That is how the sun ray appearance, rising sun appearance can be correlated with the pathophysiological mechanism of the osteosarcomatous spread. Now, what is Codman triangle? Imagine if this much of the periosteal reaction is more calcified so that it appears more on the X-ray, and rest of the periosteal reaction is not too much visible on the X-ray, it will lead to a formation of a Codman triangle kind of the appearance. Hair on end appearance. Imagine if this much of the periosteal neovascularity is more calcified, so it will appear like a increased density at the end of the tumor, so it will lead to a hair on end kind of the appearance. So when you will see the tumor, immediately you will realize that it is the osteosarcomatous tumor that I am looking at. And the basic essence of that tumor is always the periosteal reaction. Similarly, in case of Ewing sarcoma, what is happening? Imagine this is the bone and here we are having a tumor, and this tumor is prevented, and this tumor is trying to grow beyond the confines. The growth of the tumor is prevented by the periosteal layer over here. Now this periosteal layer, multiple periosteal layers beyond the confines of the bone will appear like the peels of the onion. So that is how the onion peel appearance is the name which is provided to the Ewing sarcomatous lesion. Alright. So hopefully you have understood that what is the reason behind these X-ray appearances for the malignant tumors in particular. So these are the X-ray appearances that you have to remember. Next, now rest of the X-ray findings are related to the benign tumor for its appearance and diagnosis. Now, if you look at this page, so the first finding, the sunburst appearance, the Codman triangle, the sun rays appearance, rising sun appearance, as well as hair on end appearance, as well as the onion peel appearance. This is what we have already talked about. Next is the soap bubble appearance. Soap bubble appearance is a theoretical appearance name which is given to GCT or the giant cell tumor. After that, the honeycomb appearance. Honeycomb appearance is for aneurysmal bone cyst. Then the named theoretical X-ray appearances like trapdoor sign as well as fallen leaf appearance, both of them are given to the simple bone cyst. Then we have got the irregular kind of the calcification, the calcification which is not organized, which is inhomogeneous kind of the calcification. So whenever you find this irregular calcifications which are inhomogeneous, which are disorganized or unorganized kind of the calcification, it is always a feature of cartilaginous calcification. All right. So whenever you tend to see the popcorn, like C-shaped kind of the calcification, then popcorn kind of the calcification, the inhomogeneous kind of the calcification. All right. So all of them are always the feature of a cartilaginous tumor. So the cartilaginous malignant tumor is chondrosarcoma. So it will be a feature of chondrosarcoma. Apart from this, the named X-ray findings related to the bony destruction due to fibrous dysplasia like ground glass appearance as well as Shepard-Crook deformity. Now, what happens in Shepard-Crook deformity, you will come to know when we will look at the X-rays. So, this Shepard-Crook deformity as well as ground glass appearance, both of them are the features of fibrous dysplasia. Apart from this, multiple myeloma is having a typical lytic lesions in the lumbar vertebrae. Whenever you find the word multiple lytic lesions in the lumbar vertebrae, that will go in the favor of multiple myeloma. But one spot diagnostic X-ray finding which is given in case of a skull for multiple myeloma related lesion is a punched out lytic lesion of the skull. Punched out lytic lesion. So these punched out lytic lesion is always a feature for multiple myeloma. Then for secondaries, that means for metastatic lesions, we are having a blind bat sign as well as winking owl appearance. All right. So blind bat sign as well as winking owl appearance, both of them are the features of secondaries. Apart from this, another very typical or key X-ray finding which is related to the osteoid osteoma, which is diagnostic for osteoid osteoma, and that is the radiolucent nidus. When you will see the X-ray, you can confirm it that it is the presence of a radiolucent nidus within long bone cortex, and this is the diagnostic feature for osteoid osteoma. Apart from this, now although this is something which you will never get in the form of a X-ray appearance, for the purpose of identifying the tumor, you are writing that if there is a outgrowing bony lesion which is covered by the cartilaginous cap. Now, although you cannot see the cartilaginous cap on the X-rays, but it is just for the purpose of getting introduced this term cartilaginous cap to you, so that whenever you see the word cartilaginous cap in any of the given question or in the options, then possibly they are asking about the osteochondromatous lesion, because it is a feature for osteochondroma. And then finally, the jailhouse appearance. The jailhouse appearance, also known by the name of corduroy appearance, is the feature for vertebral hemangioma. So these are the X-ray findings which you have to remember. This is considered to be the most important theoretical table related to this particular topic, that is musculoskeletal tumors of the bone. All right. So in the first one, we have talked about the histopathological reasons for these X-ray appearances of a malignant tumor, because when you see the malignant tumor, you will realize that this is the X-ray of a malignant lesion, and it is all based upon the periosteal elevation and its reaction. As far as another malignant tumor related X-ray is concerned, it is because of the speculed, inhomogeneous, irregular, C-shaped, comma-shaped kind of the calcification, which is projecting towards the cartilaginous kind of a malignant tumor. Rest of the X-ray appearances are for that of the benign tumors. All right. So with this, we have completed these important 5 tables. The first one was for the location of the tumor. Then the second one is the most common tumor. The third one is the most common tumor of the bones overall. Fourth one is the radio-resistant tumor. The fifth one is the about the age predilection, that how age, which is provided to you in the question, will help you out in reaching the diagnosis. And finally, the X-ray appearances of that particular tumor. So with this, the introductory part of the tumor is almost over, and now it will become much easier for us to identify that what is the rest which is left for that particular tumor we are going to cover in the subsequent section. So let's have a discussion on the individual tumors now. The first one is the chondroblastoma. Now already we know too many of the things related to this tumor in particular, like it is the epiphyseal tumor. The most common bone to be affected is the proximal humerus. Alright, at least this much we know about the chondroblastoma. Then the age it is likely to be affecting is less than 20 years of age. That means it is the tumor of a skeletally immature individual. So what else which is left is that it is also known as Codman tumor. You know, Codman triangle was the feature for osteosarcoma, but Codman tumor is the name which is given to this chondroblastoma. Point number 2, that histologically there are presence of the giant cells which are similarly seen in case of giant cell tumor. Alright, so histologic appearance is actually, it is a differential diagnosis of a giant cell tumor. Now, chicken wire calcification is something which is particularly seen as a biopsy finding for chondroblastomatous lesion. So this is what you have to remember. Now, the things that you have to remember in this particular section is number 1, that it is having a chicken wire calcification, which is considered to be a biopsy finding because of then we have coffee bean nuclei in the cobblestone pattern, which is again a key diagnostic finding for chondroblastomatous lesion on the histopathological appearance, and the histopathology is relatively similar to the giant cell tumor, but it is a tumor which is known by the name of Codman tumor, although Codman triangle was the feature for osteosarcoma. Next is the most important tumor for today, that is GCT, giant cell tumor. Now in the GCT, point number 1, that it is an aggressive kind of the benign tumor. We already have discussed it in the example for the aggressive benign tumor. So it consists of all the features that we have already discussed when we were talking about the aggressive kind of the benign tumor. Now point number 2, you know, in a single individual, if the patient is having multiple GCT lesions, then that patient is said to be suffering from Gold syndrome. That is, multiple GCT lesions are present in a single individual. Next, all of you know that it is an epiphyseal tumor. You know, GCT is primarily an epiphyseal tumor. But in case of a child, if the GCT is rarely appearing in case of a child, then it could be a metaphyseal tumor also. But over a period of time, when the child grows into a mature adult, then it will be again become a epiphyseal tumor. So it could be metaphyseal in a skeletally growing individuals in case of a growing child, but that too, it is a rare phenomena. It is not common. So you just have to learn this line for the possibility, not to make the complete diagnosis. For the diagnostic purpose, GCT will always be kept in the form of an epiphyseal tumor. Next, you know, 5% of the GCT has got the tendency of getting converted into a malignant lesion. Alright, if a GCT can be converted into a malignancy, the possibilities are 5%. Now, GCT can be converted into 3 malignant tumors only. It is not like that GCT can be converted into chondrosarcoma also, in any other sarcomas, fibrosarcomas. GCT has got the tendency of getting converted into 3 malignant lesions, and these are osteosarcoma, then fibrosarcoma and malignant histiocytoma. So these are the 3 tumors, malignant tumors in which GCT could be converted, and the possibility is just 5%.